How's it going, guys? We have a pass level question for hematology for step 1, internal medicine 2CK. 17-year-old girl, she's brought in for a routine physical, no past medical history. Examination shows a cut in her left index finger. She remarks that last week she cut herself and took a while to stop bleeding. Menses occur every 28 days, last 5 days, and produce clots. Laboratory studies are shown. Hemoglobin normal, 13 grams per deciliter, should be 12 to 17.5 in menstruating women, 13 to 17.5 in non-menstruating women and men. Platelets normal, 200,000 should be 150 to 450,000. Prothrombin time normal, 12 seconds should be 10 to 15 seconds. Partial thromboplastin time normal, 34 seconds should be 25 to 40 seconds. Which of the following is most likely impaired in this patient? Let's just hop through. Choice A, carboxylation of clotting factors. Wrong fucking answer. This refers to vitamin K deficiency. So vitamin K is a cofactor for an enzyme called gamma glutamyl carboxylase, which is going to activate clotting factors 2, 7, 9, 10, as well as anti-clotting proteins CNS. And we would expect a normal bleeding time as well as an elevated PT and PTT. So you can see that our PT and PTT are normal here, let alone the fact that the vignette doesn't match vitamin K deficiency. 2 ways vitamin K deficiency will present in USMLE. Number 1 is going to be a neonate who is bleeding from the umbilical stump, sometimes born at home, very buzzy. You can also get retinal hemorrhages, subconjunctival hemorrhages with vitamin K deficiency, which sounds weird because you think that's shaken baby syndrome. But if they tell you there's bleeding from the umbilical stump, that's vitamin K deficiency, even if there's red blotches on the conjunctiva. Second way it presents is going to be an adult who's been on broad spectrum antibiotics for many weeks, e.g. for endocarditis, and the answer they want is killing off the bowel flora. Okay? Wrong fucking answer. Choice B, factor 8 production, wrong fucking answer. So hemophilia A, as well as factor 9 production, hemophilia B, both wrong fucking answers. Now, this is where the USMLE can reward you, quote unquote, for knowing your inheritance pattern / genetics. It's actually fairly rare for them to give you a diagnosis and then for them to ask just straight up, what's the inheritance pattern? Hemophilias A and B are X-linked recessive. We have a girl here, so you know instantaneously that they're wrong because you only see them in males. Some students get hyperpedantic, want to read between the lines and say, well, can't you have skewed lionization, skewed X inactivation? If the USMLE ever goes that route, that will be the focus of the question. They'll literally be like, you have a girl who has hemophilia A, how is this possible? And the answer is skewed X inactivation, okay? So don't read between the lines. But if that were the case, hemophilia, it's going to be 2 presentations, either a neonatal boy who has excessive bleeding with circumcision, or it's going to be a school-age boy who has hemarthrosis bleeding into the knee, and you're going to have an isolated increase in PTT, okay, where your bleeding time and your PT are normal. Wrong fucking answers. Choice D, platelet adhesion, correct answer. So diagnosis of von Willebrand disease, it's autosomal dominant, the inheritance is extremely high yield, and the vignette is going to present 9 times out of 10 with a combination of 1 platelet problem and 1 clotting factor problem, okay? So here our platelet problem is, well, she took a while to stop bleeding. That's bleeding time. I've seen NBME do this. I believe the free 120 for 2CK has a similar question where they don't tell you the bleeding time. 2 to 7 minutes is normal. So they don't have to say bleeding time 9 minutes elevated. They'll say she just cut her finger and it took a while to stop bleeding. That's your elevated bleeding time. And then the menses are heavy. Clots within menses is a very buzzy way of saying that the menses are heavy. Okay, so menorrhagia. So they don't have to be excessively long, just clots. So memorize that. So heavy menses can be either clotting factor or platelet issue. It's usually clotting issue. They can say excessive bleeding with tooth extraction. That's also a clotting factor issue. Platelet issues, nosebleeds, petechiae, ecchymoses. So they give you the same question here. Okay, say 17-year-old girl with nosebleeds and history of excessive bleeding with tooth extraction. 17-year-old girl with random bruising / petechiae, and she's got heavy menses. Okay, so 1 platelet problem, 1 clotting factor problem. Now for the elephant in the room, some of you are going to be confused. First point to note is that your platelet count is normal for von Willebrand disease, okay? Second point to note is that your bleeding time is always elevated because the function of von Willebrand factor is to bind or bridge glycoprotein 1b on the platelet to vascular endothelium / underlying collagen. So that's platelet adhesion, that's impaired. So our bleeding time is always elevated. Now you say, but what about PTT? I thought PTT had to be elevated. Only in about half of questions, and I've inculcated this in my Heme PDF. I talked about this in other videos, that students often erroneously think that PTT and bleeding time together are always increased. It's not the case. The main function of von Willebrand factor is platelet adhesion. So bleeding time in 100% of questions is high, but it's secondary. It's a mere ancillary, a mere auxiliary role for von Willebrand factor to stabilize factor VIII in plasma. It's a mere secondary role. So because it's not the primary role, only in about half of questions PTT is elevated, okay? And this is what they did on the free 120, is they just said, took a while to stop bleeding, cutting her finger, and then the PT and PTT are normal here. And the student says, well, how do you know it's not ITP then? Okay, if you're astute. So how do you know it's not immune or idiopathic thrombocytopenic purpura where you have an isolated increase in bleeding time? It's because our platelet count's normal. Holy shit. Okay, so in ITP, obviously, platelet count is reduced. So final answer, platelet aggregation, wrong fucking answer. Glycoproteins 2B, 3A, and platelets. This is platelets sticking to each other, okay? This is going to be the answer for ITP. Okay, you have antibodies against glycoproteins 2B, 3A. So there's other more rare diagnoses students get hysterical over, obviously Glanzmann thrombasthenia for impaired platelet aggregation, deficiency of 2B, 3A, or Bernard-Solier, defective adhesion due to deficiency of 1B, but it doesn't show up in USMLE. Platelet aggregation, wrong fucking answer. You know the deal. If you make more content, if you like my stuff, subscribe my channel. Appreciate your time. That's it.